Hi everyone, I am Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we are going to break down the anatomy of inguinal canal into clear, high-yielding, exam-focused concepts. So let's get started. Now, inguinal canal is an oblique intermuscular canal. So, this canal, we see it in the lower part of the anterior abdominal wall. And this canal is formed during the descent of the testis into the scrotum during the fetal period. So, this canal here, when we see, it is about 4 centimeters long and it is directed downwards and forwards and medially. So, it is an intermuscular. So, it lies parallel to the medial half. So, this is the inguinal ligament. So, it will be lying parallel to the medial half of the inguinal ligament. So, it has an opening, at two ends, the deep ring and the superficial ring. So, this is the deep ring and here the superficial ring is present. So, the main content of this inguinal canal is spermatic cord in males and the round ligament in females. So we see the spermatic cord in males and round ligament in females. So, this inguinal canal, when we see, it extends from the deep inguinal ring up to the superficial inguinal ring. So, what we have to know is this deep inguinal ring is in the fascia transversalis. And the superficial inguinal ring. So, the deep inguinal ring is in the form of an oval opening in the fascia transversalis, whereas the superficial inguinal ring will be triangular in the external oblique aponeurosis. So, this canal is directed downwards, forwards and medially. Now, the deep inguinal ring, as I said, it is an oval opening in the fascia transversalis and it will lie about 1.25. So, the deep ring is about 1.25 centimeters above the mid-inguinal point. That is from the anterior superior iliac spine up to the pubic symphysis. So, there above the mid-inguinal point we have the deep inguinal ring located. So, from its margins, from the deep inguinal ring margin, the fascia transversalis will be prolonged into the canal, and it will be pulled along into the canal and it forms the internal spermatic fascia. So, you have to remember that the fascia transversalis, when it traverses the inguinal canal, it traverses as the internal spermatic fascia. Then the superficial inguinal ring. So, the superficial inguinal ring is a triangular gap. So, it is triangular and it is present in the external oblique aponeurosis. And this lies lateral, above and lateral. So, this will be here above and lateral. The superficial ring will be above and lateral to the pubic tubercle. So, here the pubic crest will be forming the base. Since it is triangular, it will be forming the base of this superficial inguinal ring. And the sides Okay, sides of this we call them as the crura. So at the apex, these crura will meet by the intercrural fibers. So that is about the superficial and the deep inguinal ring. Next, coming to the walls. Okay, so it has an anterior wall and a posterior wall, the roof and the floor. So when we look at the walls, okay, so here the anterior wall. So the anterior wall is formed. Okay, so walls we have the anterior wall and the posterior wall. So the anterior wall now is formed by, from when we go from outside to inside, we have the skin, then comes the superficial fascia and after that, see, abdomen doesn't have the deep fascia. So next comes the external oblique aponeurosis. Okay, so these three structures we see along the entire length, okay, of the inguinal canal. So this will be all along the entire extent of the inguinal canal, okay, and on the lateral side, okay, lateral side we will see on the lateral part, okay, will be the internal oblique muscle, okay, in lateral 1/3. So these structures form the, okay, so here basically in this picture we are seeing the external oblique muscle here. So the aponeurosis of the external oblique. Okay, so here the structure, so the anterior wall is formed by the skin, the superficial fascia, the external oblique aponeurosis, and only in the lateral 1/3 we have the internal oblique muscle fibers. So that is the anterior wall. And when we go here, we can see, okay, so this is the internal oblique. So here we saw the external oblique at the entire length. And here the lateral 1/3 we have the lateral 1/3, we have the internal oblique muscle. So when we come to the posterior wall, okay, so the posterior wall, okay, is formed like from deep to superficial. When we come, first will be the fascia transversalis. So the entire extent there will be fascia transversalis. After that we have the conjoint tendon, okay, conjoint tendon, that is formed by the transverse abdominis muscle as well as the internal oblique muscle, okay. So that conjoint tendon is you will see the conjoint tendon in the medial 2/3, okay, medial 2/3 we will see the conjoint tendon. Okay, this is the conjoint tendon. And then we will see the third thing, we will see the reflected part of the inguinal ligament. Part of inguinal ligament in the medial most part. Okay, so in this portion, medial most part will be the inguinal, reflected part of inguinal ligament. Okay, so that is the structures which are forming the posterior wall. The roof, okay, so this is, so here we can actually see this is the fascia transversalis. So now the roof, okay, the roof of the The roof is formed by the lower arched fibers of the internal oblique. Okay, so internal oblique as well as the transverse abdominis muscle fibers. So when they arch over, okay, they form the roof. The internal oblique as well as the, so roof is formed by the arched fibers of internal oblique as well as transverse abdominis muscle. And the floor, okay, so the floor is formed by the grooved upper surface, the grooved upper, so this will be the floor which will be formed by the grooved upper part of upper surface of inguinal ligament. So why we need to know all this is because these structures, some of the structures, they form the coverings of the hernia. So that is why we need to understand what are the structures forming the roof, the floor, the anterior and the posterior wall. So grooved upper surface of inguinal ligament as well as we also see the abdominal surface of lacunar ligament. Okay, so lacunar ligament at the medial part. Okay, so at the medial part we will also see the lacunar ligament. Okay, so the floor is formed by the grooved surface of the inguinal ligament as well as in the medial most part we will see the lacunar ligament. So these are the boundaries of the inguinal canal. So next when we move to the contents. So contents, the main content in males. Okay, so in the males, mainly the content is the spermatic cord, and in the females it is the males we have the spermatic cord and females we have the round ligament of uterus, So and both male and females, in addition to that we will also have the ilioinguinal nerve. Now this ilioinguinal nerve, it forms a partial content, that is it does not enter through the deep ring, it pierces through the muscle wall and then forms the content of the inguinal canal. Okay, so that is about the contents. So here, so we can see here. Okay, so the spermatic cord, along with the ilioinguinal nerve. In females, we will see the round ligament. So these are the contents which we see. Okay, so this is in the females, we see the round ligament of the uterus, and in the males we will see the spermatic cord. So just a word about the contents of the spermatic cord. Now what are the structures covering the spermatic cord? So the deepermost here we have the, from outside to inside when we come, we have the external spermatic fascia. Okay, so this is the external spermatic fascia. Then we have the cremasteric fascia. Then comes the internal spermatic fascia. Internal spermatic fascia. Okay, so those are the fascia covering there. And when we see, this is in the transverse section, the contents when we see, we have the genital branch of genitofemoral nerve, then we have the ductus deferens. So this is the ductus deferens. Okay, and around that here we are seeing the pampiniform plexus of veins. Okay, these are all the veins, pampiniform plexus of veins. Then we have the pampiniform plexus of veins surrounding that. This is the artery to the ductus deferens. And here we have the cremasteric vessels and nerve. Vessels and nerve. Okay, so this is the remnant of processus vaginalis. Processus vaginalis. And here we can see the testicular artery with the pampiniform plexus. Okay, testicular artery plus the pampiniform plexus of veins. So these structures we see within the spermatic cord. So here you have to understand that the coverings, the external spermatic fascia is derived from the aponeurosis of external oblique muscle, whereas the cremasteric fascia, it consists of loops of skeletal muscle fibers which are united by the areolar tissue. Okay, and these fibers, they are derived from the internal, basically it's the detached part of the internal oblique muscle, the cremasteric fascia. And then we have the internal spermatic fascia, which is derived from the fascia transversalis. So that is what you have to remember there. Right. So here, just to summarize the main content of the spermatic cord, here we will have the ductus deferens. Okay, ductus deferens in the posterior part surrounded by the pampiniform plexus. The three arteries we will see. Which are the three arteries? Testicular artery, artery to ductus deferens, and the cremasteric artery. Okay, and the veins, the pampiniform plexus of veins, and other than that we see also the lymphatics and the remnants of processus vaginalis. So the important thing about inguinal canal is, inguinal canal is the site for inguinal hernias, whether it is direct or indirect inguinal hernias, it is the site. Okay, especially in males. So in males the inguinal hernias are more common, whereas in females the femoral hernias are more common because of the wider pelvis. So now this inguinal canal, okay, because the hernias are common, to prevent that, okay, because whenever there is increased pressure, this abdominal threads can herniate through this canal. So to prevent that, it has its own defense mechanism. So when we see, okay, there are the inguinal canal itself, it is very obliquely placed, right? So since it is a site of potential weakness in the lower part of the abdominal wall, and it provides a site for herniation. Okay, so it is basically provided by its own strength there, the muscle, the muscle strength and the tone, it contributes to the defense mechanism. So now here we have different types of defense mechanisms. So one is the shutter mechanism. Then we have the flap valve mechanism. Then we have the slit valve mechanism. Then we have the ball valve mechanism. Okay. Then we have the guarding mechanism. So these are the main 5 mechanisms which prevents the herniation of the abdominal viscera whenever there is raised abdominal pressure. So now we will understand these different mechanisms. So when we talk about the flap valve mechanism, so what happens is the inguinal canal is oblique. Okay, so what happens, because it is oblique, the deep ring, so the deep ring is here and the superficial ring. Okay, so these two rings, they are not opposite to each other. Okay, they are not opposite to each other, so they lie obliquely. They do not lie opposite. So how this serves as a mechanism is, so whenever there is raised intra-abdominal pressure, the anterior and the posterior, like a flap, okay, the anterior and posterior walls get approximated, right? So anterior wall we knew mainly contributed by the external oblique, and in the lateral 1/3 we have the internal oblique. So the muscles contract there as whenever there is intra-abdominal pressure, and from the behind we have the, what is that, fascia transversalis, then we have the conjoint tendon formed both by the internal oblique as well as the transverse abdominis muscle. Okay, so these structures, they oppose each other, and that we call it as the flap valve mechanism. Okay, so that is the first mechanism. Next is, so shutter valve. Shutter valve mechanism is like pulling down the shutter. So whenever there is increased abdominal pressure, the roof and the floor will approximate, like the roof will come down to the floor. So it is called the shutter valve mechanism. So basically, since how that happens is the internal oblique muscle fibers, okay, so they are in the anterior also, it is forming part of the roof also, and as well as the posterior wall also. So when it contracts, what happens? It just pulls down, comes down, okay, approximates and to the floor like a shutter. Then we have so this is like the shutter mechanism. Then we have what we call as the slit valve mechanism. Okay, so slit valve mechanism, what happens? Whenever there is increased abdominal pressure, the contraction of the external oblique muscle, okay, the external oblique muscle will contract. So because of that, the superficial inguinal ring here, it becomes like a slit. Okay, because the superficial inguinal ring is within the aponeurosis of the external oblique muscle. So when it contracts, the slit gets pulled up, the triangular, the two crura of the superficial inguinal ring, they get pulled up and it forms like a slit. So that is known as the slit valve mechanism. Then we have, okay, so this is basically like the shutter mechanism here. We can see this also. Here how the fibers will contract and they pull down. Then this is like slit. Then we have the ball valve mechanism. In ball valve mechanism, what happens is the contraction of the cremasteric muscle. Okay, when the cremasteric muscle contracts, the testis is pulled upwards and the testis goes and plugs the ring, plugs the superficial inguinal ring, and that is known as the ball valve mechanism. And guarding mechanism, what happens is, so the superficial inguinal ring from behind, okay, so the superficial inguinal ring from behind is guarded by the conjoint tendon, and the deep inguinal ring from the front is guarded by the internal oblique muscle fibers. So whenever there is increased abdominal pressure, these acts as like a guard and prevents the herniation of the structures. So that is about the defense mechanism. So here a little bit about a triangle here before we go in for the clinical aspects. There is a triangle, okay, here located, which we call it as the Hesselbach's triangle. So the Hesselbach's triangle is also called as the inguinal triangle. So this is situated deep to the posterior wall. Okay, so this will be located deep to the posterior wall, of inguinal canal. So what are the boundaries of this Hesselbach's triangle? Okay, So here the medially, okay, so medially it is bounded by the lower 5 centimeters of the lateral border of the rectus abdominis muscle. So medially it is bounded by the, here it is the lateral border of rectus abdominis muscle. And laterally it is the inferior epigastric artery here. You can see. So this is the lateral boundary formed by the inferior epigastric artery. And inferiorly it is formed by the medial half. Okay, so here it is formed by the medial half of inguinal ligament. Medial half of, it's formed by the medial half of inguinal ligament. Okay, so this is the boundaries of Hesselbach's triangle. Now the floor of this triangle is covered by the peritoneal, the extraperitoneal tissue, as well as the fascia transversalis will be covering the floor. So here this triangle now, the Hesselbach's triangle. So here we can see this is the Hesselbach's triangle, which we can see here, right? So this Hesselbach's triangle by the median umbilical ligament. Okay, so what is median umbilical ligament now? It is the obliterated part of the umbilical artery. Okay, obliterated umbilical artery, that is the distal part gets obliterated, proximal part remains as the superior vesical artery. So this median umbilical artery crosses this triangle. So now this is our Hesselbach's triangle. Okay, so now this Hesselbach's triangle is crossed by this medial umbilical. Okay, not the median ligament, it is the remnant of allantois, that is the urachus. It continues as the median ligament. Medial umbilical ligament now here crosses the triangle and divides it into a medial part and a lateral part. Okay, so it divides it into a medial part and a lateral part. So the medial part here we have to understand, in the medial part the floor of the triangle will be strengthened by the conjoint ligament, and in the lateral part of the floor of the triangle here is generally weak. Okay, it's weak. So usually the direct hernias is basically due to the weakness of the abdominal wall. Okay, and we see it in adults. So this direct inguinal hernia occurs mainly to the lateral part. Okay, lateral part of the Hesselbach's triangle. So this is about the features of the Hesselbach's triangle and its clinical importance. So now we will look at the hernias. So basically in this region, the groin region, we see two types of hernias. One is the inguinal hernia. Okay, other one is the femoral hernia. So femoral hernia occurs through the femoral canal. So femoral hernia we see more common in females, F and F. Whereas the inguinal hernia is more common in males. Okay, so now basically when we say hernia, hernia is a protrusion of the abdominal viscera. Okay, through the abdominal wall we call it as the hernia. So in inguinal hernia what happens? There is protrusion of the abdominal viscera. Okay, so we see there is protrusion of the abdominal viscera, or like mainly the loop of intestine, into the inguinal canal. So this is called as the inguinal hernia. So clinically it will present as a pear-shaped swelling. Okay, a pear-shaped swelling is seen above and medial to the, where it is above and medial to the pubic tubercle. Okay, so that is just above the inguinal ligament. Now there are two types of hernias. Okay, so there is what we call it as the direct hernia and the indirect hernia. So we have to understand what is the difference between indirect inguinal hernia and the direct inguinal hernia. So, indirect inguinal hernia, okay, when we say indirect inguinal hernia, it occurs if the herniated sac enters the inguinal canal through the deep inguinal ring, okay. So, if the herniated sac, okay, or the herniated viscera, whatever is coming through the inguinal canal, it should enter the canal through the deep inguinal ring. So, then we call it as the indirect, okay. So, it has to come through the deep ring itself. So, it has to enter there, right. So, this is indirect. So, this always lies lateral to inferior epigastric artery. Inferior epigastric, that means what? It lies outside the Hesselbach's triangle. So, this inguinal hernia is outside because inferior epigastric artery is forming the lateral boundary of Hesselbach's triangle. So, that is why this the hernia, the indirect hernia is outside, okay. So, it lies outside the Hesselbach's triangle. So, this indirect inguinal hernias, right, can be congenital, so this, I'll continue here. So, indirect hernias can be congenital. Usually, they are more commonly congenital and sometimes they can be acquired, okay. So, congenital here, indirect inguinal hernias is basically due to, okay, so the congenital hernia is mainly due to the persistence, okay, because of the patent processus vaginalis. Processus vaginalis, okay. So, usually after the descent of the testis, the processus vaginalis will obliterate. But sometimes if it doesn't obliterate, it is communicating the abdominal cavity, the peritoneal cavity, okay, through the inguinal canal. So, through that communication, what happens? The structures, the abdominal viscera can be herniated, okay. So, it connects the peritoneal cavity with the tunica vaginalis. So, because of which there is a communication and it can lead to herniation. Then there is the acquired indirect. Acquired indirect, if it occurs through the deep ring, it is mainly due to increased intra-abdominal pressure due to like weightlifting and all, okay. So, sometimes here the structures can be pushed through the deep inguinal ring in this case. So, but that is acquired indirect hernia. So, the muscle strength, so here you have to remember one thing, okay, in weightlifters and all, the muscle strength will be very good, okay. So, the abdominal muscles are not weak, but because of when they are lifting the weight, because of the increased pressure there, sometimes the abdominal contents can herniate through the deep inguinal ring. Then it becomes acquired indirect hernia. So, that is about the thing. So, when we see now this is what we see as the indirect hernia. And when we look at the direct hernia, okay, so this is the direct hernias. So, direct hernia is mainly due to, this is direct hernia, okay. So, direct inguinal hernia occurs when the hernial sac enters. So, the hernial sac will enter the inguinal canal directly by pushing through the posterior wall of inguinal canal. Okay, so when it pushes through the posterior wall of the inguinal canal, so it is usually medial to the inferior epigastric artery. So this will be medial to the inferior epigastric artery, and that is in the Hesselbach's triangle. In Hesselbach's triangle. Okay. So the main difference between the direct and the indirect. Okay, indirect enters through the deep inguinal ring. Here the herniation occurs through the posterior wall of the inguinal canal. So it occurs lateral to the, that is indirect is lateral to the inferior epigastric artery. This one, that is the direct, is medial to the inferior epigastric artery. So that is outside the Hesselbach's triangle. This is within the Hesselbach's triangle. So here what happens is, if you see, the neck of the herniated sac will be very wide, and these hernias are more common in the elderly because of the abdominal weakness. So based on whether this the direct hernia can be lateral or medial, okay, lateral or medial, based on whether the hernia is lateral to the medial umbilical ligament or medial to the medial umbilical ligament. So that is about the direct and indirect hernias. So the direct inguinal hernia coverings and the indirect inguinal hernia coverings differ. So we have to understand what if it is indirect hernia, indirect inguinal hernia, what will be the coverings of the herniated structure, and if it is direct, what it will be. Okay, so first we will see the coverings of indirect inguinal hernia. Now this is the herniated loop. Okay, this is the herniated loop. So what are we going to see? So first thing here, okay, the covering will be the parietal peritoneum. Okay, so I'll mark here. So this is the parietal peritoneum. Then next comes the extraperitoneal tissue here between. Okay, we have the extraperitoneal tissue, fat and all will be present, and then comes the fascia transversalis. Okay, so the fascia transversalis, you can see it is forming the internal spermatic fascia. Okay, then we have after that, so there is the extraperitoneal tissue. So if we go from here, so we have the parietal peritoneum, then the extraperitoneal tissue, then we have the fascia transversalis, so that will be forming the internal spermatic fascia. Internal spermatic fascia. Then we have the cremasteric fascia. Formed by the detached fibers of internal oblique muscle with the areolar tissue, and then the external spermatic fascia. Okay, so these will be the external spermatic fascia, and then if we go if it goes into the scrotum, then we have the dartus muscle as well as the skin and all those things which form the covering. So basically these are the most important coverings of the indirect inguinal hernia. So indirect inguinal hernia is when it occurs through the deep inguinal ring. Then if the hernia is direct, so in direct hernia we have two kinds, lateral and medial, based on whether it is lateral to the medial umbilical ligament or medial to the medial umbilical ligament. So first we will see the lateral one. Okay, so the lateral direct hernia. So here what will be the coverings? So if you see, first will be this is the herniated loop. So after that we have the parietal peritoneum. So here you have to remember we are talking about lateral. Lateral means it is so outside the obliterated umbilical ligament, okay, the lateral aspect of umbilical ligament. So this parietal peritoneum, then we have the extraperitoneal tissue, then we have the fascia transversalis, okay, we see the fascia transversalis, then we see the cremasteric fascia, and we see the external spermatic fascia. So what did you see here? We didn't see the internal spermatic fascia, external spermatic fascia. Okay, so these are the coverings, okay, which forms the covering for external lateral direct hernias. I am repeating here. So these are the structures which form the covering for lateral direct hernia. So coming to the medial direct hernia, okay, the medial direct hernia. So when you talk about the medial direct hernia now, so medial means it is medial to the obliterated umbilical ligament, that is the medial obliterated umbilical artery, that is the medial umbilical ligament. So it is medial. So here what will be the structure now? We have the parietal peritoneum, the same thing, the parietal peritoneum is there. Then we have the extraperitoneal connective tissue. Then we have the fascia transversalis, of course. Then we have the conjoint tendon. Okay, so conjoint tendon we will see here. Conjoint tendon. And we will see we don't see the cremasteric fascia there. Conjoint tendon is seen and we see the external spermatic fascia. So this is how the coverings will differ for the medial, the lateral, direct hernias and indirect inguinal hernias. So now let's solve some of the image based MCQs. So the marked structure is, here it is marked in the fascia transversalis, so it is the deep inguinal ring. Which structure forms the medial boundary of the marked triangle? So the marked triangle is this one. So the medial boundary is the lateral border of rectus abdominis. So it is the rectus abdominis muscle. And what is that triangle? It is Hesselbach's or inguinal triangle. The label structure most likely contains, which is the label structure here. Okay, here it is labeled. So it contains, so this is the spermatic cord. So spermatic cord will not have round ligament, will not have femoral artery, will not have inferior epigastric artery. So the content is ductus deferens and the campaniform plexus of veins, testicular vessels. Right. The internal spermatic fascia. Okay, so internal spermatic fascia is derived from fascia transversalis or transversalis fascia. External oblique aponeurosis forms the external spermatic fascia. Internal oblique muscle forms the cremasteric fascia. The type of hernia. Okay. So we have the Hesselbach's triangle here. This is the Hesselbach's triangle. So what type of hernia it is? It is the direct inguinal hernia. So that's a wrap on today's session of inguinal canal and inguinal hernias. So stay consistent with this series, which is going to bring you one step closer to your NEET PG dream. Stay consistent, stay focused and trust in your preparation. I'll see you in the next session.